Welcome to Hand Expression and Alternative Feeding Methods, the second webinar in our four-part Breastfeeding Skills Session webinar series. I am Amy Gold, the Director of Education for the Partnership for Maternal and Child Health of Northern New Jersey. The partnership is providing today's program. A few pieces of information before I introduce our speakers. The speakers and planners have no relevant conflicts of interest. To receive a certificate of completion, you must listen to the entire webinar and complete the evaluation survey. Within 1 hour after the webinar ends, you will receive an email with a link to that survey. Certificates of completion will be sent via email next week. This program is being recorded and will be available via the Partnership's on-demand education page until September 9th, 2022. Our first speaker is Sharon Tanis, the Manager for Lactation at the Valley Hospital in Ridgewood. Sharon is a master's prepared nurse as well as an international board-certified lactation consultant. In her current role, she coordinates and provides both inpatient and outpatient breastfeeding support services. Sharon will be discussing hand expression.
Welcome, everybody. I'm Sharon, and I'll be talking about hand expression today. Hormones are the typical start of milk removal. However, it is important to have early, frequent, and effective removal of colostrum, which determines the future for production. When we talk about our low-risk newborns, typically we do attachment, breast milk production, and calories, the ABCs. The longer the delay, the more risk of dysfunctional suck when we don't latch babies as soon as possible. Breast milk production starts within the first hour rather than the first 1 to 6 hours because of higher oxytocin. So the more we latch, the more we take milk out of the breast, the better off it is. Milk volume equals duration and exclusivity. Calories then become important. Because the needs are smaller, colostrum only has about 80% of the calories needed. Therefore, babies use their own reserves. Now we're going to talk about the infant who's at risk or at high risk. Notice our ABCs are in opposite order. The most important thing we think about is the calories of these babies. Because they don't have those excess reserves, it's important to get these babies the calories as soon as possible. So how do we do that? Sometimes babies have issues when they are trying to latch. So the earlier we can express this milk by using our hands or a pump, the better off we are. Breast milk production we can try to do this with hand expression at least 5 times daily. The last thing we focus on is attachment. Again, this should be our least worry as we want to focus on getting those calories. We want to do as much skin to skin. And attachment, we can expend a lot of energy with these babies and we don't want to tire them out. If production is high, transition to the breast is a lot easier. So why should we hand express? It's more effective at removing colostrum than a pump. Colostrum is extremely thick and often we lose those drops on the pump pieces rather than expressing directly into a vial or onto a spoon. Trouble latching. When we hand express drops and feed to our baby via spoon, we give our baby more energy. We give them the drops that they need. Often these babies who are at higher risk are separated and therefore unable to breastfeed. These babies can be in the neonatal intensive care unit, or they are just separated from their moms being in the transition nursery, Therefore, expressing for them is extremely important. If babies have tried to latch, but we don't find that they're exchanging enough, with hand expression, it allows for a supplementation. Instead of going directly to formula, we can have mom's hand express and either give it to her baby via a syringe or a spoon. Hand expression is also important for moms who have very full or engorged breasts. Often it's very difficult to latch babies on a very hard breast. Therefore, if we teach mom to hand express and soften those breasts, it makes latching a lot easier. Often moms, if they are away from their baby, say for instance, you had a doctor's appointment, you're at work, you had no access to a pump, we have our own two hands where we are able to express and get some milk out. So hand expression, as you can see, is extremely important. So how do we hand express? We're going to place our thumb and index finger behind our areola. We're going to move our hand back towards our chest and bring the pads of our fingers together in rhythmic motion. Then we're going to pull into the chest and not move out towards our nipple. It is extremely important that a mom does not place her fingers on her areola or pinch her nipple. Often that causes pain, and then moms don't want to hand express. What I'm going to do is I'm going to actually show you on a breast model how to do hand expression. So you'll have to excuse my very large breast here, but I'm going to help you to understand where your hands are going to be placed. You want to make sure your hand is in a very large C position, okay? Notice I'm not on the areola or the nipple. Again, very painful for a mom. We always ask permission before we actually start helping her to hand express. I never want to hand express for a mom. I want to be able to assist her with her hands on her breast as well. So often, if I was the patient, I would have her hand on the opposite side so that we can do it together. Now notice my finger movement, very large at first, and what I'm going to do is slightly press down. Then what I want to do is push back towards the chest wall and squeeze my fingers together. Back towards the chest wall and squeeze my fingers together. I'm not running my fingers towards the areola. When I do that, I can actually block off the ducts, not allowing the milk to move freely. So again, big wide C, squeeze slightly together, back to the chest wall and pinch my fingers together. Remember, there's ducts all around the breast. So I want to focus on many different areas of the breast. Again, underneath, squeeze fingers together, back to the chest wall, and pinch together. Before I start hand expressing, as often moms are very upset after they've done it for a few minutes, that nothing comes out. But before I even start, I want to do breast massage all the way around, okay? I also want to put warm compresses on my breast to get those ducts activated and opened up. I want to think about the breast like an IV bag, okay? When I put the tubing attached, it doesn't automatically start dripping out. I have to run the fluids to the bottom of the IV line. So the same thing about a breast. If I don't get it ready to work, I shouldn't expect anything to come out. So breast massage first, nice warm compress, and then hand placement. Again, no fingers on the areola and no fingers on the nipple. Here's a little bit a website that you can all go ahead and watch. This is by Jane Morton, and it's an excellent, excellent video to actually teach you how to do hand expression. Excellent for your patients, okay? Again, you want to prepare that. Often, as you will see in Jane Morton's video, she'll put Band-Aid markers on the breast so the patients know exactly where to place their hands so that we don't cause pain for these moms, and they're able to do this later on when we leave. It's also, what do I do with that milk once I start collecting it? There are small little vials that you can give the patients, okay? Here at our hospital, we supply each mom with a hand expression card. There's an expression card that has a spoon attached to it. On that card is also beautiful directions on how to do hand expression. So we supply each of our moms with a card that looks like these. This comes from the catalog Noodle Soup. If you see on the back, excellent directions on hand placement and how to do the hand expression, okay? At our hospital, we also prepare a little packet. And this is what we give to each of our patients so that they can prepare for hand expression. Small little vial. Why small? If I hand a mom a 2-ounce bottle or a 3-ounce bottle, what is she going to think? Wow, I have to hand express that much? It doesn't make them feel good if they only get a couple of drops that land in the bottom of the bottle, or for that matter, because colostrum's so thick, get caught in the pump parts. Then what do you see? They're running to the NICU with a flange because there's 1 drop on it. It's so much easier to hand express into a small vial. Just a couple of drops, fill the bottom of the vial. How does mom feel? She feels really good about this. We will give them spoons. They're pre-wrapped, so we don't have to worry, okay, that they've been in somebody's pocket, touched something else. Unwrap them, mom can express right onto here. If we have a full-term baby, a wide-awake baby, we can go ahead and feed this to them right away. But with our small vials, we breast milk label them properly, and we can store them in the refrigerator or in the NICU so that we can be able to give them to them later on. We often have the question from our NICU moms, if I hand express and I only hand express 1 drop, what am I supposed to do with it? Well, at our hospital, we want our patients to bring that 1 drop, 2 drops, it doesn't matter. We want them to bring it immediately to the NICU, okay? Within an hour, those drops have to be brought there. We don't want moms storing from this time that she hand expressed, saving it for another hour and adding another drop to it. We want her to be able to give those drops to the NICU as soon as possible and not mix the times that she pumped or hand expressed. We want our moms to hand express, again, because that colostrum is so thick. Often we find that those drops get stuck on the pump parts. So therefore, it's a lot easier to hand express. And I want to be hand expressing even if I am pumping.
Thank you so much, Sharon, for that terrific presentation. We do have time for a few questions, if you don't mind.
No, that's fine.
The first one is, if I'm pumping, do I still need to hand express?
Hand expression is very important to do in conjunction with pumping. As I mentioned earlier, is that colostrum is very thick. So often when we are assisting a mom with hand expression or even pumping, and we happen to touch some of the colostrum, which may sound a little bit strange to some people, but our hands are gloved, you will notice that the colostrum is actually very thick and sticky. So what that means is that when it comes out and it gets on the flange, it doesn't easily roll into the flange and down to the bottom of the bottle. Often it gets stuck in those tiny little pieces of the pump. Sometimes when moms pump, they might pump for 15, 20 minutes and nothing comes out, and they feel frustrated with that. Then we have them hand express. And what happens is those thick drops of colostrum sit on the end of the nipple. And therefore, we're able to easily collect that again into a spoon or into a small vial. So very, very important not to just do pumping, but also to do hand expression along with it. Excellent question.
And how often do people have to hand express? What do you recommend for your moms?
Again, it's going to depend on what else is going on. Is that baby latching well? If the baby isn't latching well and we're only pumping, we ask that moms stimulate their breasts at least 7 to 8 times in a 24-hour period. Along with pumping, we want them to do being hand expression. So we should be doing hand expression about the same time. And again, once moms are really good at hand expression, and again, I highly recommend watching that video. Often moms are hand expression becomes a lot easier than setting themselves with a pump. Obviously, once you start getting large volumes and you're beyond filling that 4 ml vial and you're moving to bottles, moms may not have the strength in their hands to continue to pump to get ounces, but it definitely can be the start for the pumping or even the end of the pumping, especially in the very beginning, when taking out milk is what tells our body to make more milk. So the sooner we can start hand expression after delivery, and like I mentioned very early on, within that first hour, that is ideal. That's what sets the ground for our good supply weeks down the road. So the quicker I can hand express, do that along with pumping, the better.
And when someone's hand expressing, how long do they hand express on each side?
So the whole process may take 10, 15 minutes. Remember, it's so important to prep that breast. I very often in the hospital will hear nurses frustrated, parents frustrated. I tried hand expressing and nothing came out. My first question is, what did you do to prepare the breast? As I mentioned, it's very important to start breast massage first, and then you want to put warm compresses on the breast. So that you can expect should take a good 5 minutes. And then you want to start hand expressing. And it's important, you have 2 breasts. So if you start here, you want to move to the other side. When we pump, we teach a mom to pump both breasts at the same time. So we can't just hand express here and go and then leave and expect next time to come in the opposite breast. We want to think about both breasts at the same time. So it's massage on both, warm compresses on both, and go back and forth, which you'll also see in the video from Jane Morton, that she works on both breasts at the same time. And we can assist mom with one breast while her hands are on the opposite breast.
Great, thank you. And how much milk would a mom expect to produce when she hand expresses, especially in the beginning?
Exactly. In the very beginning, she might only get a couple of drops. That's why it's so important. When we give mom something to put her milk in, I don't want to hand her a 2-ounce bottle. I really want to focus on giving her something small. This is only a couple mLs. So just a few drops will actually make it look like there's something in here. So we're not going to expect volume. Our breasts don't produce volume in the beginning. Remember, everybody, stomachs are only the size of about marbles the first couple of days of life. So isn't a 2-ounce bottle appropriate for a stomach the size of a marble? No, but our bodies know that. Hence why they only produce a few little drops to fill that size stomach the next couple of days. And for some moms, it might be 3 to 5 days. For other moms, it might take 5 to 7+ days before their milk comes in. So to answer the question directly, just a few drops each time she hand express until her volume actually kicks in.
And what do you say to a mom who's discouraged because she's only producing a small amount when she hand expresses?
We want to explain to moms that it's completely normal. She shouldn't expect that her breasts are going to be like faucets. just pouring out milk. It takes time, and it's important. If I take a drop out, my body realizes it has to make another drop. So it's important to keep trying and to keep encouraging her that the more I do this, the more I try, the more hopefully those drops will come out and the production will increase.
Excellent. Thank you so much for spending time with us this afternoon, Sharon.
Thank you for inviting me to do this.
Our second speaker is Carmen Baker-Clark, an international board-certified lactation consultant with her undergraduate degree in art and archaeology from Princeton University. A former La Leche leader and WIC breastfeeding manager, Carmen has been the manager for the lactation program at Hoboken University Medical Center and Christ Hospital since 2012. Carmen's topic for today is alternative feeding methods. Welcome, Carmen.
Thank you, Amy, and hello, everyone. The topic for today, alternative feeding devices, is for supplementation of infants. We want to always prioritize the choice of supplement. Of course, always first, according to the Academy of Breastfeeding Medicine, is express mom's breast milk or colostrum. If that isn't available for whatever reason, we want to use pasteurized donor breast milk if that is available at your hospital. Otherwise, the next is protein hydrolysate formulas, which are easier on the baby's system. If that is not available, then you go into regular infant formula, and lastly, soy formula. The average reported intakes of colostrum for an infant usually are in the first 24 hours about 2 to 10 milliliters per feed, okay? Second 24 hours, the volume is hopefully increasing to 5 to 15, and the third 24 hours from 15 to 30 or more. Factors to consider when selecting an alternative feeding method. So depending on the circumstances, of course, cost and availability. Is this something easy and easily accessible? Is it easy to use and to clean? Is it stressful for the infant or for the mother to use? Whether the adequate milk volume can be fed in a reasonable amount of time, such as 20 to 30 minutes. Whether anticipated use is short or long term. Maternal preference needs to be considered. And also, very importantly, if we want to preserve the breastfeeding relationship, is this method enhancing the development of breastfeeding skills for the infant and the mother? Why we do not want to use supplemental feeding through bottle feeding? It really can be kind of an obstacle because the bottle will not promote proper biomechanics of breastfeeding. With the typical bottles offered in the hospitals as an alternative to feed your baby, they tend to be a long, narrow teat that the baby will very easily simply just bite using gums or jaw pressure to get milk out instead of proper tongue movement and cheek movement. So the flow will be much faster, and the baby will have to develop different ways of swallowing that milk. It makes it much harder to establish a breastfeeding relationship if the baby receives a supplemental bottle first. And also, as in the 9th step of the 10 steps to successful breastfeeding for baby-friendly hospitals, it states that bottle nibbles in hospitals should be avoided as it conveys an endorsement by healthcare professionals, making parents more likely to continue or start to use bottles, leading to the early cessation of breastfeeding. This is something very important to take into consideration when we offer that as the first way of supplementing an infant. We really would like to preserve the breastfeeding relationship. So when do you have to use an alternative method of feeding? When the baby is unable to latch onto the breast for whatever reason, when the mother is not present on the unit, if there's mother-baby separation, when the parents and staff wish to avoid supplementing the infant with a bottle, and when breastfeeding is not possible for any reason. Sometimes babies are not able to latch or to transfer milk well, even though they appear to be latched due to different reasons. So when a healthcare provider, a lactation consultant, or a nurse assisting a mother with latch, she may notice that the baby is very sleepy. The mother may have a very long labor, a long epidural resulting in a very sleepy baby. Maybe mother had a long induction and then a C-section. So there's a lot to take into consideration there. Maybe this mother has flat, inelastic, or inverted nipple tissue, or nipple tissue that is everted but dimples inwards when the baby attempts to latch. Maybe the mother had a lot of IV fluids and she has already developed edema of the breast, further stretching the nipple tissue so that the baby cannot latch on easily. In a situation like that, I often recommend doing reverse pressure softening, which is a technique where you press along and I'm going to use my Ruby model, along the edges of the breast to just basically remove or push back some of that excess fluid around the breast. Sometimes babies have tongue tie, they have tethered oral tissues, lip ties, tongue ties, cheek ties, and doesn't allow them to use their tongue correctly. Sometimes they have tongue thrusts where you try to latch them on, they kind of latch on for 2 seconds and they push the tongue out. Sometimes they have a little jaw asymmetry, which is probably caused normally by the positioning in the utero. Sometimes they have torticollis, which is a head turning preference to one side with a tilt or to the other side with a tilt. Sometimes it's very difficult to position a baby like that on the breast, causing mom a lot of pain. Pain is another reason why sometimes we want to use an alternative feeding method or quick and fast damage to the nipples. We might need to let the nipples rest a little bit, use hand expression, and then feed the baby a different way. Sometimes you have babies who have a congenital malformation or an illness, and they need to be supplemented a different way. Mom or baby are too sick to breastfeed. Maybe supplementation has been medically ordered because the baby is large for gestational age, small for gestational age, has low blood sugar, or is already Coombs positive or developing quick high levels of jaundice. Sometimes you have a mom, if you look at her maternal history, who has, a breast reduction, augmentation surgery, a lumpectomy, even pierced nipples can sometimes interfere with the flow of breast milk through the nipple. Maybe she has a history of gestational diabetes, type 1 or type 2 diabetes, signs of insulin resistance. She may be at risk for low milk production. IVF, IUI, a history of irregular periods, or early onset or prolonged use of oral contraceptives can sometimes interfere with milk production or the development of sufficient glandular tissue for her to be able to have plentiful milk production. PCOS, and if she's on thyroid medication, you have to investigate why, and even high blood pressure, that can interfere. These are all circumstances that we have to carefully observe, assess, take into account, because they may have an impact on the success of this mom's breastfeeding journey. So here's a little baby spoon feeding. Easy access in any setting. Oops, sorry. No risk, no cost, reusable, readily available, convenient for collecting and delivering small volumes. As you can see in this photo, this baby's the spoon is lightly placed on top of its lower lip, and the baby immediately sticks its tongue out, tasting a little bit of colostrum. So this is promoting breastfeeding skills because it's enabling or stimulating baby's tongue extension reflex to lick and mobilize that tongue, and then maybe even take in the colostrum and swallow it carefully. If I were to do this, here's my little baby doll. You can either swaddle the baby or hold the arms down, and you just kind of like keep the baby upright. This is for a full-term baby who is, got good reflexes. And you just stop and you just kind of like give them a little bit, wait and see how they handle that first little few drops of colostrum. If they smack their lips, if they swallow it well, then you can give a little bit more. The more you give, the better, the more practice the baby gets, the better he gets at it, the more confident. Parents can easily do this as well with your proper demonstration. Then you have cup feeding. It's been shown to be safe for both term and preterm infants and may help to preserve our breastfeeding duration for those who require multiple supplemental feedings. So spoon feeding is actually wonderful because you can just rescue a situation that just need one or two, interventions. Cup feeding may be necessary when the interventions are a little bit more long-term and the baby is going to be drinking bigger volumes. I personally like these flexi cups. Again, keep the baby upright, hold the baby's hands down, squeeze the cup a little bit just over the baby's lower lip, tip it a little bit until the baby can taste, stick its tongue out. When you tap the lower lip, the baby wants to extend the tongue out. So then he'll taste the milk and then he'll begin lapping it up, just kind of like a little kitty cat. Again, watch that the baby is actually drinking and swallowing well. It's not appropriate to cup feed a baby that has been extubated with possible damage to vocal cords, has a poor gag reflex, is extremely lethargic, has neurological deficit, and his respiratory unstable condition. Here's a nice graphic, both if you swaddle or if you just don't swaddle, where you're keeping the baby in that upright position and tight and close to your body so you can control baby movement. Lower lip in contact, tilt the cup just far enough so that the baby can taste the milk, and that will inspire the baby to get a little bit more. Here's another different type of cup feeding device called the Nifty Feeding Cup. It's like a little lip there. And here's a nice image of a baby in the UK being cup fed, swaddled. So dropper feeding is another way of feeding an infant, and it can be done primarily by using finger feeding. I prefer to do finger feeding. So if I will wash my hands, glove my hands, or I'll teach the parents to wash their hands and have short nails clipped, they can basically use either a dropper, a curved syringe, such as this Monoject. I love this one. I think there's a picture here. You basically latch the baby onto your finger, nail side down, pat side up. Sometimes if you rub the palate, that will initiate the sucking reflex on the baby's part. Then you can insert the tip of the curve into the baby's mouth through the corner of the mouth and pointing into the cheek. That way, and then with the other hand, of course, or with the help of another adult, you can push the plunger down. Sometimes some babies have a strong enough reflex, suck reflex, or they establish a really good vacuum that they can actually draw the milk all by themselves. Another way of doing this is using different size syringes, 1 ml, 3 ml, 10 ml, and attach a French number 5 tubing to it. oops, sorry, such as this one. And again, you tape it to your finger and somebody helps you by plunging just amounts. Again, you latch the baby on. These methods are extremely useful because as a lactation consultant, you can assess how well the baby is using its oral anatomy. Is it extending the tongue over the lower gum line? Is it wrapping its tongue around the finger? Can you feel proper peristalsis of the tongue? Can you feel vacuum, or can you easily slip your finger out of the baby's mouth? This is very helpful in determining whether this baby can latch onto the breast, sustain a latch, and have effective milk removal from the breast. It can also be done to reward the baby when it's actually sucking correctly by giving them a little bit more milk and not giving milk when the baby's not sucking well. So it can be used for suck training. You can also encourage the baby to do proper tongue movements by massaging the roof of the mouth and by pressing down onto the tongue. So not only is it a supplemental feeding device, but it's a suck training device as well. Of course, always when doing these, observe the baby for its suck swallow pattern, particularly make sure that the baby's actually swallowing. Now, this is a finger feeder from Medela that also gets attached to the tip of the syringe. And again, it can be used with your finger, both into the baby's mouth, and it's soft and gentle, so sometimes babies do really well with it. So then we go on to our supplemental nursing systems. These are used for more long-term use, and it also depends on the parent's willingness to use something like this, because these can be a little bit awkward to use, a little difficult to clean, they may be a little bit more expensive, and they require moderately complex learning. But the advantage is that if this is only also for a baby that's actually latching well, and the mother's problem is more like her supply is low, and you want to supplement this baby at the breast with increased flow for whatever medical reason, the baby needs more milk, can be given this way. And it can be whatever is available that the mother has a great milk supply, fantastic. It can be pumped and put into the supplemental nursing system. If we need to use an alternative milk, then that can be used as well. But then the baby is latching both onto the tube of the supplemental nursing system and the breast at the same time, and when the baby is sucking and drinking, it's actually stimulating the flow of the milk. So the starter SNS is this one. As you can see the picture of it there. And again, the same thing, this can be either taped onto the breast, and the baby latches onto both the breast and the tube. There's a valve that is released here. So it's like this, and it's released, and then this can be pumped until it fills up, and then as the baby sucks, so the baby has to be able to establish some sort of vacuum, then the milk will be pulled down through the tubing and into the baby. And then the baby sucks, stimulates breast milk production in the breast, and gets fed at the same time. This could be a short-term use situation. And then, of course, you have the starter, the supplemental nursing system, the big one, where you can actually do this for parents who really do need a long-term solution, and they're willing to do this. When I'm working with parents who need something like this, I always let them know that they don't have to do every feeding like this. They can do half the feedings like this. Many times these are parents who really want to breastfeed but are not able to produce enough milk. And they want to have that breastfeeding experience of having the baby at the breast, eating, feeding, being happy, and looking up at them, you know, that whole falling in love cycle of oxytocin production and feeding your baby at the breast. Sometimes we encounter babies who have special needs, such as cleft lip and cleft palate in the hospital. And these special needs feeder is designed for a baby that is unable to create vacuum. They're pretty simple to use. We're grateful that we have them, and they help a baby draw milk at a rate that they are comfortable with. Again, same idea as the starter system. You know, you kind of pump this until the milk that's in here, it fills it up a little bit, and then it has 3 lines, one for slow flow, medium flow, and faster flow, and you just line that up to the nose of the baby, and then the baby can, you know, drink from it at a pace that they are comfortable and they feel safe in. You can also use the teat to block off, you know, clefts. This is another one that's also very interesting. It's the soft cough, and it's ideal for short term. And babies with sucking difficulties, babies that tend to choke or gag a lot. Again, they want to just take a small amount, move it around in the mouth, form a bolus, and they're swallowed. These are really good for babies. I mean, the soft cough and the soft cough feeder are very helpful for babies who are having difficulty with coordinating suck swallow. This is a comparison of supplementation methods. It's a handout that you can have available to you, can be mailed to you at the end of when you receive your emails. And these are the references that I used to put together this presentation. I just wanted to say a couple of things about ways to stimulate milk production for a mom. In addition to the hand expression and the pumping, very oftentimes when I check a mom for her production immediately after or before the delivery of her baby, or immediately after the delivery of her baby, she may not have very much, maybe just what I call vapor, or just one faint glisten of a drop of colostrum. But after we do an hour or two of skin-to-skin contact, and we check again for colostrum production, even if the baby hasn't latched, we will see a whole lot more colostrum coming out. So it's very important to take that into consideration and to help encourage a lot more skin-to-skin contact throughout the hospital stay. It's a way of connecting mother and baby, and it's a way for empowering mom to determine her own milk production by doing lots of skin-to-skin contact. So that's it for now. Do we have any questions?
Great. Yes, we do actually have a few questions for you, Carmen. And the first one's actually from me. So I remember back in the dark ages when I was a nurse working on the maternity unit, and people were first starting to talk about using cup feeding. We thought that was really strange, and that we couldn't believe that newborns would be able to drink from a cup. And there was also a concern that the baby might choke. So if staff does have those kind of concerns, how do you address those?
So that's something difficult to answer because.
Sorry.
No, that's fine. It's a great question. Thank you, because we encounter this a lot in our hospital. First of all, they have to be kind of skilled at setting the baby up and positioning the baby correctly so that the baby is actually quite upright, and you can control the flow and only tip a little bit of milk into the baby's mouth to see how the baby handles the fluid. Now, these days, there's a lot of babies with sucking difficulties. At least I'm working with a lot of babies who have difficulty coordinating suck, swallow, breathing. And something like cup feeding would not be appropriate in that circumstance, especially if the parents tell you that the baby gags a lot, or has a lot of gurgling sounds in the back of the throat, or even just with breastfeeding or any kind of other method of feeding, they feel like the baby's always going to choke. So I think nurses who have experienced that will be very hesitant to use a cup feeding method.
Mm.
But when you have a baby who is full term, who is competent, who has a good, after being assessed by the lactation consultant, the baby has a good suck, swallow, creates good vacuum, and you can feel good movement of the tongue, then but mom can't direct breastfeed, that's an appropriate time to choose cup feeding, okay? Because it is going to encourage the baby to stick the tongue out and use the tongue to lap up the milk and then swallow. But sometimes cup feeding is not appropriate in every situation. So I can understand why they would be hesitant, especially if they have experienced a baby gagging or choking on their wine.
Right.
But it's something that it's important to learn how to do, because there are times that it can be extremely helpful.
Thank you. So in that same vein of questioning, when you mentioned that cup feeding wasn't appropriate in all situations, what's the method of supplementation that you use most in the hospital setting, and why?
Usually, most of the time, I'm being called in to intervene immediately after the birth of the baby when the baby is not latching. And that's exactly when I want to, the skin to skin will be extremely helpful because it'll get the colostrum flowing, but we need to get the food into the baby for various reasons. The nurses and everybody wants to document that first feeding. So if the baby is not latching within that hour or within those first 2 hours, somehow we have to get, for the sake of the mother, we begin to remove milk to activate the milk production. And then we have to get that milk into the baby. If a mom only has a little bit of colostrum, then a spoon will be perfectly fine. And again, I'll right then and there, with the help of dad, I'll enlist them. I'll say, okay, just help me. I'll show him how to do that, and then we'll supplement that baby. Again, also it's an opportunity for me to assess, how is this baby using its tongue? How is it sucking? And then I'll determine whether I feel comfortable encouraging to continue to do this kind of supplemental feeding or not. So I have to be very involved in the assessment of the situation, so that we don't have it, even with little bits of colostrum. Sometimes, colostrum is very thick and viscousy and sticky, kind of like the consistency of honey or molasses. So basically, when we're putting into a baby's mouth, it kind of sticks all on the inside of the mouth. It coats the tongue, the cheeks, and then it slowly, gets swallowed. And again, it begins to coat the baby's digestive system, which is what it's intended to do. But again, when we're talking of bigger volumes, then it's a lot more liquidy and fluid, and that baby needs to learn how to. Or some moms have really liquidy colostrum in the beginning too. So again, careful assessment and judgment. If we have a lot of colostrum right off the bat, I'll pull out one of our, Snappy's 11 ml collection containers. I'll collect, and I alternate from side to side to side to side. If a mom is able at that time, immediately after birth, if she's comfortable enough and she's able to, I'll, work with her, have her work on one side while I work on the other. If she's had a C-section and she's not really feeling well, then I have to do a lot of the hand expression and show dad how to do some of the hand expression as well. Then we will pour it into the spoon and then feed it to the baby. So again,
can you hold your baby up a little more so we can see it, and with the spoon? Yeah.
I keep them pretty upright. I can either do the tip or I can do the side, depending, and how well. Sometimes it really sticks to the spoon, so I might just paint it on the baby's lips and then the baby pick it up.
Great. Can you, since you have the baby lifted up, could you also just show the syringe using the curved tip of the syringe?
What do we do with it? The curved tip syringe. It's gone missing. Oh, here it is. Right for mine. So again, for ease, I tend to just line up the curved syringe to my finger, or just place it kind of on top like that. I don't know if you can see that.
Mm-hmm.
Then I have the baby, the aim is so that the curved tip is going to end up in the baby's cheek. So I always present the finger to the nose or the upper lip. I wait for the baby to gape or open wide. Then I will place my finger inside the baby's mouth. Once I feel the baby begin suckling, then I will deliver a little bit of colostrum. And if the baby handles that well and continues to suckle, I deliver a little bit more. Sometimes, like I said, some babies will have very strong vacuum and they're able actually to even make this move on its own. Okay, that makes me happy, because I know this baby should be able to do a great job at the breast if it's doing it all by itself. But this is also this would be like kind of my second choice, because especially if a mom has a lot more volume of colostrum, this will hold 12 milliliters of fluid. And so I know that if I fill it up to the top, I know that I've fed a fair amount. Something really good to use generally on day 2 if mom has that kind of volume on day 2. Of course, mom will be pumping and hand expressing, set up with pumping and hand expressing to help her.
They go hand in hand. Can you talk a little bit about what suck training is?
So
your elevator speech.
My elevator speech. Well, it's like suck evaluation and suck training at the same time. I am trying to feel what the baby does with its tongue. And it should really be feeling as if they're wrapping their little tongue and making like a hot dog out of my finger. Mm-hmm. And then on top of that, they have to do this peristalsis, this lift of the tip, lift of the middle, lift of the back, and drop of the back while sucking. If a baby's sliding its tongue like this on my finger and almost pushing it out, I know this is going to be a tough one. The baby's going to do the same exact thing to mom's nipple. Right. It's going to be pushing that nipple out. So I have to kind of like be a detective and try and figure out, why is this baby do this? It's not easy to figure out sometimes. Very often we find a tethered oral tissue underneath the tongue, that either the baby's tethered right to the tip or slightly behind the tip, or sometimes it could be one of those sneaky posterior tongue ties, which are really problematic because they're not obvious, they're not easily seen, and because they're not easily seen, they think there's nothing, no tie, but the baby isn't able to move its tongue appropriately. That could be one reason. Second reason could be the forces of labor. We had a long 36-hour labor and then a long pushing stage, and the baby is born and there's some flat spots, some bruising, maybe even a little swelling. That baby's gonna not want to suck as well. So maybe that's why the baby is not sucking. So suck training is helpful, because I reward the baby when he's sucking correctly, but sometimes babies just can't do it. Not because they don't want to, not because they never experience it, because they just need to live outside of the womb and recover from birth themselves for 24 to 48 hours or sometimes more. And sometimes there's an indication to recommend them to get some type of helpful body work. And in the meantime, we have to get the baby fed. So that's when sometimes a long-term supplemental feeding method. And I didn't even touch upon, what if this mother doesn't want to use a supplemental nursing system? She just wants a bottle. Then I would recommend a bottle that's a little bit more compatible with breastfeeding, that has a nice tapered shape, We have a short tip nipple that's soft and flexible, and a base that gradually broadens wide, so that it helps the baby open the mouth wide, as opposed to the ones that our hospital systems provide, which is kind of very long and narrow and doesn't encourage a nice wide mouth opening. Also flows very fast.
Thank you.
So
And I know we will be talking about pace bottle feeding in the fourth lecture of this series. So that's a nice lead-in for that. Yes, terrific. Okay. So I think we have time for one last question.
sure.
When choosing a method, what are you assessing for when you look at the baby?
But we kind of touch upon that a little bit, but I look at the whole baby. I look at how the baby holds itself. Does it hold itself straight or does it tilt and twist? You know, and I can't, no matter what we do, we can't get the baby to straighten out. So, you know, and the baby can't sustain a latch in any position. You know, so that's one factor. I look at tether oral tissues. If we can't sustain a latch, again, doing a quick assessment. I will the size of the baby relative, the baby's mouth size relative to the mother's breast size and nipple tissue. So if you have a mother with a very large breast and a very large nipple, and we have a 5.5 pound baby, we're going to have a little bit of a challenge. Mother may be producing milk great, baby may be sucking perfectly fine on my finger, but we just can't put them together. So that's another example that comes to mind. But the whole time is, I always tell parents that this is temporary, that this is just a little bridge to get you to a place where the baby gets better. You know, if it's body tightness, that'll resolve itself eventually, you know, with some help, maybe some more than just a little help. The baby's, if it's tiny, the baby will grow, you know. They'll eventually be able to suck better if we do some of the suck training exercises. I mean, just simple things like tapping on the lower lip here to get the baby to, when you tap here, you elicit the extension reflex, so the baby's going to go, or the side to side, you know, you go from side to side. That just is like little exercise to mobilize the tongue a little bit more. It's also a way for me to assess, do we have good tongue mobility? Do we have good extension, good lateral movement, good elevation? That's very telling. Whether how much can this baby do to sustain a latch for the duration of the feeding. Sometimes they stay on, but they're not drinking. We haven't talked about that. So I do a lot of education of parents, telling them, see, your baby's on and it's moving its mouth a little bit, but I'm hearing 0 swallows, or maybe 1 or 2 swallows in 25 minutes. That's not a feeding. So that I will actually, again, that will be another way, another assessment that I do. I observe a whole feeding to be sure that this baby is actually drinking at breast. And that will be a determinant. I will say to that mom, you must pump or you must hand express at the end of that feeding and supplement that baby with your pump colostrum, because I feel the baby is not draining your breast of whatever little bit of colostrum that you may have.
Great. Thank you. Thank you for your very thorough answers and for being with us this afternoon.
My pleasure, Amy. Always great to be here. Thank you.
That's all we have time for today. Many thanks to our speakers and to Monica Smith, who handled the technical back end of our program. A reminder that in about an hour, you will receive an email with a link to the post-program evaluation. Certificates of completion will be sent via email next week, and we'll be using the email that you provide on your evaluation, so please double check to make sure there are no typos in it. Our breastfeeding webinar series will continue next Thursday, September 17th, with some of our regional lactation consultants presenting supporting breastfeeding in the NICU and case studies. In addition to our webinars for professionals, the partnership has a variety of resources to support new mothers who are breastfeeding. Our Sisters Who Breastfeed program in Paterson and Jersey City is a collaboration with the Perinatal Health Equity Foundation. This support village is for Black women who are breastfeeding or plan to breastfeed and offers virtual support, connections, and resources. We appreciate any referrals that you may have for this group. More information about our education programs and our resources can be found at our website, partnershipmch.org. Thank you for joining today's program. We hope you can join us next week.